would like to now invite our next speaker to the stage. We are inviting Dr. Eric Osborn. He is the chair of the MCS ECMO task force and part of the CHEST organization. He's going to be giving us a discussion about common ECMO challenges. Please, everyone, welcome Dr. Eric Osborn. Thanks. Enjoy.
All right, good morning. I want to thank the Heartbeat Perfusions, Mohammed, Matt, and Leslie and the team for, it's an honor to be here in such distinguished company. My name's Eric. I'm an ECMO physician. I'm thinking, everybody here, who's a perfusionist? That's awesome. Everybody here. So I was in the Army, and one of our first super long ECMO transports, we didn't have a military perfusionist where I was. So what do? We were new, we're learning. I said, well, we're not going until we get a very experienced perfusionist to come with us. And they said, you can't do that. You're going to put a civilian on a military plane? We don't do that. And I said, well, yeah, why not? Why not? Let's make an exception. Let's get on the phone. So I ended up talking to the Secretary of the Air Force, and I said, well, we can make an exception and we can put this very experienced perfusionist who happens to be a civilian on our flight, and you can save a life, or you can let this young soldier die. So it's a testament to how important it was when we were just starting, because we didn't really know what we were doing. This was a long time ago, and we ended up doing, at the time, one of the longest ECMO transports that had been recorded. And the great irony was everybody thought that that was like the hardest and the most difficult thing to do. And actually, you guys know this, once they're on ECMO and they're stable, it's actually a lot easier. This was V-V. Once they're on V-V ECMO and you've taken care of their gas exchange with a ECMO circuit, that's a lot easier than flying someone across the world on rescue ventilator settings. So it's a testament. I'm glad to be here with a bunch of perfusionists. I learned a lot from you guys. I still do, a long time ago. I'm going to talk about some common ECMO challenges. And I want to talk about, I did sports, a lot of sports when I was younger. I still do them now. And we have these crazy coaches. And we were getting ready for a championship, one of our championships. And the coach said, you guys want to win? We said, yeah, of course. Yeah, we want to win. He said, are you committed? Oh, yeah, we're committed. How committed are you? Well, yeah, we want to win, coach. Are you chickens or are you pigs? And we're sitting there thinking, what? Chickens or pigs? Well, what do you mean, coach? This is about commitment. The team that wins is the team that wants it more. The chicken just lays the eggs, walks around. The pig becomes the ham. That's commitment. And we're like, well, can we be a wild boar? I mean, you're saying this is life and death, but at that level where we were, that's how important it was. It was life and death. And here we are talking about extracorporeal support, and it's literally about life and death. And we heard about Lucy, who has a life now because of the technology that Richard was working on. And the commitment we have, there's a calling to go into medicine. There's an extra calling to get into cardiac surgery and perfusion. And then when I'm hiring ECMO physicians, I came up through pulmonary critical care. So I started doing it when the only people I was able to hang out with that were pro-ECMO, this was like 20 years ago, were perfusionists, pediatricians, neonatologists, and cardiac surgeons. My colleagues didn't believe in ECMO. They thought I was crazy. I'm getting off on a tangent, but it talks about the level of commitment that we have to have. We're going to talk about a 32-year-old pregnant woman with blue lips. We're going to talk about bleeding, infection, hypoxia, and mobility. Some challenges for ECMO. This is Gia. She's 32. She's 33 weeks pregnant. She was born in Korea. She came over here. She now is writing, she writes questions for the SATs. So it was bright. She goes to routine OB appointment. Fingers are blue. Her saturations are 75%. She's hypotensive. She wants to go back to work. Said, oh, this is just normal pregnancy. This is her first baby, by the way. So we do an echo. It shows a massive ASD. right to left shunt after a long-standing left to right. So Eisenmenger's, you guys know this, but so you have severe right heart failure, and she has severe pulmonary hypertension. So she's got impending cardiopulmonary failure. The right heart is gone. Now this is for a lot of my adult medical audiences. They don't always aren't familiar with Eisenmenger's. You guys are. So this is just a graphic for it. So she has progressive cardiopulmonary failure. Her right heart has completely failed. So we know that intubation carries the risk of RV suicide. And if you've tried to intubate someone whose RV is gone and they go into PEA arrest, they don't come back. They really don't. They don't come back. You have to get them on ECMO right away. So then you're crashing on ECMO. So what do? This is her ABG. She's hanging in there. She's compensated. She's been living with this ASD that's been developing slowly over time. She's hypotensive. We get her on norepi, milrinone, vasopressin, lactates rising a little bit, MAP still in the mid-50s. So, and this is in the adult cardiac ICU. One of our surgeons said she needs a heart-lung transplant, but we don't do that here, and she's too sick. It's too late. If you try to fix it, she's going to die. She's going to lose the child. And these were some of our more experienced and senior physicians saying, well, you should call palliative care because it's too late. You think we're going to do that? No. But it shows you that's a mentality that's out there. And that was real. I'm not saying one is right or one is wrong, but we're saying that we're here committed to doing everything we can to save this woman's life and her baby. So we put in a swan. Her PAPI, as you guys know, good sign of right heart function is down. Her right heart is completely down. High pulmonary pressures. Her cardiac power output is really low. Cardiac index is also low. This is on support. She's ashen. She has rails. LFTs and BNP are high, but she's still mentating. So she is in multi-organ failure from progressive right heart failure. Now she's got some left heart failure as a result of that. What are we going to do? So this is the background. She's 33 weeks pregnant, got severe respiratory and right heart failure now. She's maxed out on high flow nitric oxide. She's in SCI stage C and D, so that's where you start having hypoperfusion and end organ. E is when you're going on to ECMO. We start thinking about mechanical circulatory support at stage C, which is your classic shock. If you have shock, and as soon as you have evidence of end organ hypoperfusion, lactates going up, your liver LFTs are going up, your kidneys struggling, then you want to give them support right away. I'm an absolute advocate for early support. That's my bias. That's fine. That's my disclosure. I believe in ECMO. I believe in mechanical circulatory support. I have for a long time. I used to get in trouble for it. Now we've got evidence that it shows it works in adults. This is ECMO. So what are we going to do? Transfer to a center that can perform heart-lung, start IV epoprostenol, call palliative care, awake intubation, deliver the child, start pulmonary hypertension meds, awake ECMO, intubate, deliver child IV Remodulin. Anybody want to call palliative care? It's okay if you do. How about transfer? Anybody want to transfer? All right. How about just tube her, deliver the child, and put her on meds? She hasn't been treated. So when you talk to the pulmonary hypertension experts, 33 chronic congenital heart disease, she's used to this level of hypoxia, and she hasn't been treated. So give her a chance of being treated before you commit her to a heart-lung transplant. There's about 10 of them done a year. You guys probably know better than me. There are not very many that are done. They can be done, but that's a big operation, someone 33. Or who wants to do D, awake ECMO, intubate, deliver the child, start IV Remodulin? I'll take your silence as a yes. Yeah, or I see some head nods. All right, so we put her on awake, fem via ECMO, and then we did a planned C-section. Baby comes out okay. She has uterine bleeding postpartum. She gets embolized. So we fixed that. That was actually a really big bleed. We fixed it, but then they tried to put an NG tube in, just a little tube. Now she's on ECMO, she's heparinized, she's on IV Remodulin, so that'll antagonize your platelet function a little bit. And she bleeds into her lungs, and she bled a lot into her lungs. She gets a Pseudomonas infection, gets resistant to Zosyn. A couple days later, it's resistant to meropenem. A couple days later, now we're giving Avicaz. So the new one, it's a Ceftaz, Avibactam. That you have to get like a transplant ID person to approve. So her right heart gets better with some venous drainage on the ECMO cannula, diuresis, and we treat her pulmonary hypertension. But her lungs are still really sick. So we take her off of VA ECMO. So we remove her femoral lines and we put in a right IJ. Only 27 French. They said she's really small. We were advocating for something larger, but that's a discussion. You know, I think me and the perfusionist wanted to put in a 31. The surgeon at that time wanted to put in a 27. So that's okay. Movie quote, only the young people can answer this. You guys know where that's from? Older people? The Shining, there you go. So this is the most common complication. I like this picture. So people don't usually die from bleeding. So I came up in the military, and we say no one should die from blood loss, because you can replace blood. No one dies from a pneumothorax because you can put in a chest tube. No one dies from a pericardial tamponade because you can put in you can do a pericardiocentesis. Those are some things. Now they do, but if you can get blood in fast enough, the coagulopathy that can develop can cause problems, and it can lead to circuit changes and lead to infection and bleeding and organ failure. But it's the most common complication, as you know, in ECMO, but it's usually not the cause of death. With one caveat, unless they bleed into the head. And that's my one area I have nightmares about for our ECMO patients. But let's get back to Gia. So we took care of her bleeding, but the bleeding into her lungs had caused this really bad pseudomonal infection. We talked about the resistance. We figured out if we stood her up and moved her around, it helped her O2 saturations. So her lungs start getting a little bit better. She's 90% tubed. Her right heart is improving. So she gets extubated. Now she's satting 65%. A little bit low. People are freaking out, but we're an ECMO center. We're a high-volume ECMO center. We're used to this. She's mentating. Her lactate's okay. So our goal saturation was actually 60%. But it comes to shift change. Of course, it's a Friday night. Her sats drop down to 53%. Mental status is normal. Her cardiac output and her hemoglobin are both high. So right heart is still down, but the left heart is picked up now. Our goal sat was greater than 60, but 53, she's blue. That's low. That's low, even for a congenital heart patient. She's on her iPhone, and she's typing complex sentences on her iPhone. And I'm here during the day, but you can't stay there 24/7, so we have our night ICU doc, and he comes in, look, he's a good doc, senior, he's not an ECMO physician. He says, I have to intubate her. I mean, I can't sit here with sats in the 50s. I said, well, Jack, do you? Do you? So the RV suicide is real. You guys know that. You've seen it. I've seen it too many times. Did not want to intubate her. It's also a step back. We needed the mobility for pulmonary clearance to get her lungs better. So what are you going to do? So to recover, we're recently extubated, sats in the 60s. She's got this bad Pseudomonas infection. Her lactate's okay. She's typing complex sentences on her iPhone. She's maxed out on high flow and INO. So the ECMO flow is maxed at 3 liters, limited due to the 27 French cannula. She was small. We couldn't get any higher on that. What do you want to do? So we want to intubate her awake with anesthesia. We can convert her to VA. But her heart was getting better. So mobilize patient, continue diuresis, serial lactates, place another ECMO drainage cannula to achieve more flow. We could. I told her, I said, when the night guy comes in, actually, I'll come in with you, but I'm going to stay in the back. I want you to smile and look as happy and healthy as you can. And the nurse is like, her lips are blue. I'm like, I know, but we want to do something. Do you think we intubated her? Kind of told you the answer. No. What are we going to do? 53 is too low. I get it. And she was blue. But here's the thing. Was she in anaerobic metabolism? Her lactate was normal. She's mentating. She was hanging in there. So we walked her. Seems counterintuitive. They're like, you're crazy. We can't. She's 53. I said, listen, we did it earlier today. She got better. So we stayed. There's a lot of people here, and we walked her, and she got better. Now, this is going from SATs in the 50s up to SATs in the 80s, but congenital cardiac patient, it worked. So very counterintuitive. And you guys probably were new enough that, well, we're just going to get her up and move her around. If you're talking to non-ECMO audiences, nobody says get her up and move her around with SATs in the 50s, because we're so conditioned on, oh, that pulse ox, it's too low. It's too low. Her hemoglobin was high, her cardiac output was okay, she was compensating, her lactate was normal, she was mentating. Here she is, she got reunited with her baby, Noah. Noah's like 4 now and is doing great. So the instructive principles for this story: dangers of intubation for severe RV failure. Risk of RV suicide, be very careful. You have a refractory PA arrest, they don't come back. Inadequate dosing of anti-infective meds. You give them the highest doses that your pharmacist will let you do. And something like this. Why? The circuit sucks it up, the volume of distribution is higher, resistance develops very quickly. And that's what happened here. We didn't give her high enough doses. Accepting hypoxia in certain situations. We're looking at tissue level oxygenation, not just one number. We'll talk about oxygen delivery in a minute. And the great healing powers of mobility. In cardiac surgery, we know that. We get patients up all the time. Not so much in the medical ICUs, where a lot of these patients are taken care of. They're not used to that. It's a different culture. So you really have to work, and you have to go in sometimes and do it yourself, and have the nurses say, well, you're doing it wrong, and then have physical therapy say, well, you're doing it wrong, but you're doing it, and then they'll start doing it the right way. I mean, maybe we're doing it the right. We were doing it, but they have certain ways of doing transfers and stuff like this. So these 2 guys, the first 2 human beings to use the cardio help in Hawaii. Getting which is not here, so we thank Abbott and we thank Medtronic for their support. We talked them into sending us the cardio help to Hawaii before it was approved, and we used it at a conference. So we hooked up one of their teddy bears to the ECMO circuit in our living room. And they had those quick connectors, and my sons took it apart, and they had 4 liters of. Thankfully, we didn't have dye in it yet, but it was shooting across the living room. And next we did it outside. That was our backyard in Hawaii. So this is a little bit subtle. The big cat is the ECMO team. The small cat is the cardiopulmonary failure. I hope we can understand what this means. No animals were harmed during that video. So let's talk about oxygen delivery. One of the common challenges, this is V-V ECMO we're mostly talking about, but it also applies to VA. Oxygen delivery, hemoglobin, your oxygen saturation, 0.003 times your PaO2. The point here is, and there's a lot of adult intensivists, adult providers, on all different specialties that will just look at your PaO2. What's the PaO2? What contribution does the PaO2 in that equation? It's so small you can actually cross it off. It's a good marker for disease activity, but it's the dissolved blood. As you all know, it's just a reminder, because we all know this, but we don't practice this way. We look at the PaO2 because it's on an ABG. Oh, the PaO2 is okay, so I want that up. A good waveform, a good oxygen saturation is actually much more valuable, and even a good NIRS form. You know, I hear you. I don't think they're as accurate when it gets really cold. We do our cooling down to 33, and I think it works there. But when you go into your circ arrest, your 25, not as accurate. But your pulse ox with a good waveform is way more accurate. The PO2 is still valuable as a marker of disease progression. But it's the dissolved. 99% of your oxygen is bound to hemoglobin, and that's your saturation. Anesthesiologist at altitude. You guys remember this one. This was from New England Journal of Medicine. So a bunch of Irish anesthesiologists say, hey, let's climb up to Mount Everest and do blood gases on ourselves. And they took samples. They got up to the top. Their sats were 34%, 44%. So we just talked about how important the saturation is, and it is for oxygen delivery. But if you're a healthy person and your cardiac output's good and your hemoglobin is high, these guys were walking around, they were doing ABGs on each other on Mount Everest. And they were okay. Now, they weren't cognitively as fast as they would be, but they went down and they practiced their normal anesthesiologist lives. It shows you what levels of hypoxia the human body can accept, can withstand, other things being equal. There's a very important caveat in this, is that if you're in shock, it's different. And if you're in septic shock specifically, it's different, because you have an oxygen extraction problem on the cellular level. So this does not apply if you're in septic shock, but if you're a VV guy, a patient with a pneumonia, and your blood pressure is okay and your heart's okay, you'd be surprised what levels of hypoxia people can tolerate. So what's the partial pressure of oxygen? Going back to our PaO2, inside a cell necessary to sustain life. The guy's closer to the, it's less than 9.9 inside a mitochondria. That's the partial pressure of oxygen. In your brain, maybe my brain's a little lower. Your guys' brains, healthy brains, 34. There's some variabilities in here, but it shows you, this is why you have someone like Gia, that pregnant patient who was hanging out with SATs in the 50s, and she was okay. Because inside, she was getting enough oxygen into her cells to keep going your oxidative phosphorylation and your mitochondrial, all that stuff was still working. Because the partial pressure is actually a lot lower than we think. All right, this is easy. Is this oxygenator working? Yes or no? That's a yes. You look at the color, red, blue, totally. You can see that from across the room. So this guy's circuit is working, at least from an oxygen standpoint. Let's do Bob and Jim. Who is getting less oxygen delivered? The story of Bob and Jim. Bob is 44. He's got a pneumonia. He's on 4 liters of V-V ECMO. Jim is 38. He's on 4.5 liters of V-V ECMO. He also has pneumonia. Jim is SAT is 94. Bob is SAT is 64. All right, you look at that, you're like, oh, well, Jim is doing much better than Bob. But we go back to our oxygen delivery equation, hemoglobin, cardiac output, and we can think about, it's easy, it's a mathematical equation to content the oxygen content of blood. So Bob's hemoglobin is 14, Jim's hemoglobin is 9. Now Bob is got kidney and liver failure. Jim has got some right heart dysfunction, he's on milrinone. Who has the higher content in their blood and who survived? Yes, you guys are quick, good. So it's just a simple calculation, they're close, but actually Bob, now you have to take a step back and think about it, because so many people look at that and they're like, oh, well, Bob's in trouble, SAT is 64, oh my goodness. You might be able to do the caveat, well, Jim is also in a little bit of shock because he's on milrinone. This is just an extreme illustrative point to show that you want to look at all of the different factors of oxygen delivery and not get hung up on the saturation. This is Mike Myers, respiratory failure, unknown illness, 13 days on the ventilator, large air leak. One of my colleagues tried to do a transbronchial lung biopsy when he was on high levels of PEEP. I know you guys aren't pulmonologists, but don't do that. So he had a leak. He's failing conventional rescue modes. We got a call during we were doing a DCD, we got a call, it's Friday night. They said, can you come to Japan? I was in Hawaii, he's in Japan. Because of some political challenges between the Marines and the Japanese government, he was actually in Okinawa, they were refusing to take care of him. Japan has some great ECMO. Osaka's got a great, even Okinawa has some great ECMO, but they were refusing to take him. He was stuck on the ventilator with respiratory failure. 13 days. 13 days on the ventilator. This is day 2. You could say, well, there's that 7-day rule, after 7 days, they don't do as well. In this situation, it doesn't apply. That 7 days is old data. It came back into prominence because of COVID, and we had to ration care because of resource allocation. But the 7 days, we don't actually use that. We look at the whole I'll talk about that tomorrow. So here he is, day 2 of ECMO. He's following commands, writing to us. We put him on ECMO in Japan, flew him back to Hawaii. This is where I said I'm not going unless I have a perfusionist. This was a long time ago. We get massive bleeding in Hawaii. We gave him antithrombin because we were working with pediatric people, and that's what they did. His antithrombin was low. Unfortunately, he got an extra dose of antithrombin, so double dose. That was a mistake we made. We were new. What do you think happened? He bled. He bled and bled. I did a bronch with my boss because my boss was like, oh, I've never bronched an ECMO patient. You're crazy for putting him on ECMO, but I want to do the bronch. So we're going in, and we get to the right middle lobe, and there's a big clot there. I say, leave it, leave it. Reflexively, when you're doing a bronch, you go and you want to clean stuff out. You have a suction device, and it's really satisfying. You're sucking out blood and mucus. He just sucked out the clot. These on antithrombin, heparin, ECMO, he started bleeding. He didn't stop. He didn't stop. So the lesson there is don't let your boss who doesn't know ECMO do the bronch. I was trying to be nice, and I figured he would listen to me, but why would your boss listen to you? I mean, whose bosses listen to that? Sometimes they do. But anyway, again, judgment call on my mistake. He bled a lot, and that's a problem. Once you start bleeding into the lungs that are already injured, it's hard to get them to stop. So we were a smaller hospital in Hawaii. He bled, and he was using a lot of blood, and we needed to take him to a place. He didn't get better. We needed to take him to a place that was more experienced, had more. This was about 15 years ago. And then we take a step back, and people start saying, he's sitting there in Hawaii, bleeding, not getting better. So then the command comes to me and says, was ECMO the right choice? Look, I looked this up, and he was on 13 days. It says after 7 days you shouldn't put him on. His CO2 was really high. That's a marker for bad outcomes. He had a long duration of high airway pressures. So he was not on lung protective ventilation in Japan. And he's bleeding. So was it? Was it the right choice? I said yes, absolutely it was. If we don't have data, follow physiology. So right now, as you guys are sitting there trying to stay awake, what's the pressure in your lungs when you inhale? You take a breath in. If I could slip a little micro catheter in there and measure the pressure in your lungs, it's negative 5 centimeters of water. It's negative. Wait a minute. So we're a negative pressure organism. That's our natural physiology, is negative pressure. When somebody gets sick and they have a pneumonia, we put them on a ventilator and we give them positive pressure. We've been doing that for 54 or 55 years. Then what do we do if some positive pressure doesn't work? We give them more, and we call it something different because now we have microprocessors, and we can call it APRV and high flow and PRVC. It's all just giving more pressure at different parts of the respiratory cycle. Does that help the lungs? No. No, it doesn't. It's actually counterintuitive. So why do we think it's like you break your leg. This is a crude analogy, but it kind of makes sense to me. Maybe I'm simple, but it's like breaking your leg and say, okay, we're going to have you walk on your leg. Oh, wait, walking didn't work? Okay, let's have you jump up and down on your leg. Maybe that'll help. Well, a lot of times it doesn't. It doesn't. So in people that have severe ARDS, as much as 25 to 30% of them, they're not going to get better on a ventilator. You get them on ECMO early, and then you take away the ventilator I was teaching a course on mechanical ventilation, and I had a slide, the ventilator as a murder weapon, and the director of the course said, you can't put that up there. This is a course about mechanical ventilation. It saves lives. It does to a point, not the sickest people. So he's not improving, just justifying why this guy needed. He also had an air leak, and he had severe ARDS. So absolutely, he needed ECMO. So we take him, we decide, listen, okay, we were new, it's like 15 years ago, our institution was not used to long ECMO runs. This was actually the first adult ECMO patient in Hawaii. So that just shows you how far we've come. Now, I'm excluding your cardiac surgery patients. Obviously, they were doing cardiac surgery in Hawaii, and they would put some of those post-ops on ECMO briefly, for heart surgery patients, but this was the first respiratory failure in the hospital in Hawaii. This is only 15 years ago. So we said, okay, we'll take him to one of my mentors, Bill Lynch, was at Iowa. Now he's at Michigan. He's a cardiac surgeon. We're going to fly him to Iowa. So 3 hours in flight, he has low oxygen. We're actually over the Pacific, so we can't land. His oxygen and SpO2 is 64%. So again, we hadn't been through GIA yet, and this was early on, so we were freaking out about his low oxygen. 3 hours of flight, his mixed venous is 48%. We did push up his hemoglobin. His pulse ox is low. It's going to be loud. Who's paying on the volume in the back here? What are you going to do? So we pushed up his cardiac output. ECMO flow was at 6 liters. His vent was PEEP of 8. Tidal volume was only 120 because he was completely collapsed. Remember, he filled up his lungs with blood. What do? You're in the air. We're sitting here. We're thinking we're frying this guy's brain because he's hypoxic. This is my backyard in Hawaii. You take a moment and reflect. Am I going to go into the pool or the ocean or both? Now, I was renting. I couldn't afford this. I was a starving Army doctor. We were renting this house on the ocean. So what do you do with hypoxia on V-V ECMO? Common occurrence, oxygenator function. You want your PO2 to be above 300. That's what I use. A lot of people use 250. When you first go on, you're going to be over 500 with a fresh one, right? ECMO blood flow, you can increase your ECMO blood flow. Prone positioning. Now, actually, the one thing I have not done in the air is prone someone. We could totally do that now because that's one good thing of COVID. Everybody prones all the time, and it works. Decrease metabolic oxygen demand, sedate, cool him, we did that. Increases cardiac output, we did that. Increases oxygen content in his blood, we did that. Increase the ventilator support if possible, we can do that. Vasodilator therapy. His tidal volume was only 120, will it work? It might. A little more detail, we look at the cannula position on ultrasound. So he had a 31 French Avalon, so with echo, we made sure that the jet was returning to the right atrium. Look at the circuit, and you guys are the experts here. His oxygenator function was compromised. I mean, he had thrombosis in his oxygenator because he was bleeding so much in Hawaii. What I know now is we should have switched it out before we got on the plane. Bill Lynch, who I'd been talking to, said, oh, it'll be okay, just take it. We were used to flying people with fresh oxygenators, and we didn't notice any difference because we were on the flat portion of the oxygen dissociation curve. So we were flying people all the time and didn't have an issue with it. On average, you go up in an air, your SAT will drop maybe 4%, not a big deal, even if your lungs are sick. If you're on the steep portion, which he was because his oxygenator was already compromised, then a little bit of change, that's why he was having so much problems. We could add another oxygenator. Again, doing that in flight, I did talk to our perfusionist about it, and she said, well, I think he's going to be okay. We had never done that before. Change the circuit in flight. Cabin altitude restriction. So that will increase the partial pressure of oxygen, but you do that at the expense, it slows down the plane because you're flying at a lower altitude. And when we did the calculations, it didn't make that much of a difference. Cabin was already pressurized to like 8,000 feet. Cool patient, already paralyzed. How about vasodilator therapy? Not going to hurt. You know, they said it wouldn't do anything, but we did vasodilator therapy and turned up his vent and see what happened. So pretty much right away it went up to 80%, and I was surprised by that. We were just using Flowland through a mini heart nebulizer, and it happened pretty fast. I don't know why this guy isn't wearing gloves. That's our nebulizer right there. Are you guys able to turn the sound on? We'll need it for the last video. You can see some of the junk that's in the oxygenator. This was the pre-cardio help, so it dates us. And The Air Force did like $1 million grant to develop this sled, which is a great sled, great transport sled, but then pretty quickly it was rendered obsolete by the smaller devices. Here's our ventilator, and you'll look at the settings, and these are settings you don't want to use because they're really high. People survive on V-V ECMO because you can do very low, ultra-protective lung ventilation. So his volume was super low. We reversed his ID. His partial pressure was 40, map of airway pressure of 30. So that's a lot. PEEP is 16. Did we have to? So shortly after he gets better, should we be concerned about his hypoxia? Now, I would have just said, oh, we'll ride it out. Don't worry about it. Back then, we were nervous. We were legitimately nervous about his head. Did you need to increase the ventilator settings? Probably not. We were sort of in panic mode. Let's do what we can. So 38 days of ECMO, complex course at Tripler and at Iowa. He has a long problem. He had a couple of cardiac arrests at Iowa. He had renal failure. He had multiple infections. Is his brain okay? He has prolonged hypoxia, both with us in the transport, and he has hypoxia at Iowa. He has cardiac arrest twice in Iowa. Immediate CPR, epi ×1 with ROSC. Immediate CPR, he got shocked a couple times. He came back really fast. Basal gerish reflex. We'll talk about that later. Renal failure, multiple infections, fasciotomy, left arm infiltrated, prolonged bleeding. So this video is non-medical, but it shows you what happened. And there's a song on here, but I'm not going to sing for you. So this was in, I can narrate, I guess. This was in Okinawa. And you'll see some civilians in there. Those are the people that the Secretary of Defense authorized. Plenty of manpower, but this was also before we'd done a lot of transports. So right now the audio is just a song, but later on it's important to hear the audio because it shows you how his brain is doing. They had it before. So this video, The Power of Marketing, this video helped us get a grant to we were one of the places that had the buy ECMO machines out in Hawaii. Louise, you just want me to sing, don't you? So plenty of manpower, but then again, these are not ECMO experienced people. The perfusionists had spent a lot of time and about 20 years doing perfusion and done some transport. So that was the key person to have for a flight with people that were new to ECMO. So at the time, this was a long time ago, but these were the longest flights, adult ECMO at the time. Since then, the Swedes took someone from Sweden to Australia, and Polly Palmer said he did that just so that we could say that we no longer had this, so that he could say his transport was longer than ours. But that's awesome. That was the pilot who was sleeping. It was a nice sled. You don't really need it anymore, but at the time it worked out. And that's Dr. Lynch with the glasses. We flew to Iowa because initially got a bed in San Diego, and then they canceled the bed at the last minute. So we had to make alternate arrangements, and I knew Dr. Lynch, so. That's okay. So he sounds actually really normal. So we knew he survived at the time. Again, I know a lot more now. I was really nervous about his head. So what 23-year-old wants to survive if they don't have a normal cognitive function? So he actually ended up doing really well. And those cardiac arrests that he had, I think it's a variant of the basal gyrus reflex, which is when you have your jet hitting the sinus node or the AV node, or it hits the cardiac conduction system in just the right way, they get this reflex bradycardia and then can go into PEA, because he comes back really fast. And I've seen this happen in multiple cardiac V-V ECMO patients, and they do fine, because you code them like you would anybody else. You look at the circuit, make sure that's working, then you do your CPR, you give them the drugs, you turn up the vent, and then they end up doing very well. So instructive principles from this case: the selection criteria are fluid. I'll talk about this more tomorrow. They're dynamic and best individualized. The 7-day ventilator rule doesn't always apply. Avoid long flights with a compromised oxygenator. Again, we should have switched it out, and I know that now. We do it all the time, but surprising amounts of hypoxia can be tolerated if your cardiac output and hemoglobin is normal. We know that. It still is hard, and you can draw out the equations, you can show people videos, but when they're looking at a pulse ox in the 70s or 60s, everybody's uncomfortable. The surgeons, the nurses, the ECMO specialist, everybody is. But you can tolerate a lot of hypoxia, assuming you're not in shock, you don't have a cellular oxygen extraction issue. So those are important caveats, but a lot of these people, they're not. He wasn't in shock. Cardiac arrest on V-V ECMO, that's conduction system reflex. Look up basal gyrus. This would explain it. It hasn't been used for this particular phenomenon. Well-tolerated, normal ACLS, CPR, meds, check your circuit, we know that. And as we know, and all you know, the lungs and brain have greater regenerative powers than we previously knew. We've been able to keep people alive longer. So that's my name and number. Take it down. Feel free to contact me. I hope the people online, thank you for joining us.